Welcome to the Deep Dive. Today we're going deep into a really complex and frankly critical topic in eye health. Glaucoma.
Absolutely, it's a big one.
Yeah, and we've got this detailed source document, absolutely packed with information. Our mission here is to really unpack everything in it.
Everything.
We're talking the core mechanisms of how the damage happens, how we classify it, diagnose it, all the different types, the management principles, just going as deep as this source lets us. We want you to feel like you've truly mastered this subject by the end.
That's the goal. And right off the bat, the source makes it clear. Glaucoma isn't just one single disease. It's actually a group of conditions.
Okay, a group. But they share something fundamental.
They do. At their core, they involve what's called a chronic progressive optic neuropathy.
Chronic progressive, meaning ongoing worsening damage.
Exactly. Damage to the optic nerve specifically. And over time, that leads to a loss of visual function.
So the optic nerve, that's the cable carrying vision signals to the brain, right? And glaucoma messes with that cable. What's the main villain here, according to our source? The primary risk factor.
The number one known risk factor highlighted is raised intraocular pressure. IOP for short.
IOP. The pressure inside the eye goes up. Okay? But why? What makes it go up?
Well, the source points primarily to a sort of a plumbing problem in the eye.
Plumbing?
Yeah, there's increased resistance to the drainage of the aqueous humor. That's the clear fluid filling the front part of the eye.
So fluid is made, but it can't drain out properly.
Right. The resistance usually builds up in what's called the angle of the anterior chamber. That's where the eye's main drainage system sits.
Specifically within that system.
Often it's within a spongy tissue called the trabecular meshwork. Think of it like the eye's filter or drain.
Got it. The drain gets clogged.
Or sometimes the circulation of that aqueous fluid gets blocked right at the pupil itself.
Okay, so the fluid is produced, but the exit is blocked or slow. Our source mentioned outflow pathways.
Yes, two main ones. The major pathway is through that trabecular meshwork, then into a channel called Schlemm's canal. That's the main drain.
And a second one.
There's also a secondary route, the uveoscleral pathway. It handles some additional drainage.
But it's not enough to compensate if the main drain is blocked.
Generally, no, especially not for significant blockages or sudden pressure changes. The trabecular meshwork route is really the workhorse.
Okay, let's really dive into how this pressure, or maybe other things, actually damages that optic nerve. This is the core pathogenesis, right?
Exactly. The source explains the damage isn't just one thing. It's a combination of interlinked factors affecting the health of the axons.
Axons, the nerve fibers making up the optic nerve.
Correct. And the source details two main influences driving the damage.
Which are?
First, mechanical changes caused by that high pressure. And second, altered or decreased vascular perfusion, basically. Problems with the blood supply to the optic nerve head.
Let's break down the mechanical part first. How does high pressure physically hurt those nerve fibers?
The source gets quite specific. The high IOP puts pressure on the lamina cribrosa.
Lamina cribrosa. Remind us.
It's this unique sort of sieve-like structure at the back of the eye where all the optic nerve fibers bundle together to exit. Normally, it provides support.
Like a scaffold.
Exactly. But high pressure physically deforms it, pushes on it. Initially, this mechanical stress can mess with blood flow in the tiny capillaries there, and it can decrease something called axoplasmic flow.
Axoplasmic flow. The transport system within the nerves.
Yes, moving vital stuff along the nerve fiber. If the pressure stays high, the actual plates of this lamina cribrosa can get pushed backward and compacted.
Seriously, pushed back.
Yes, and this physically narrows the little openings the nerve fibers pass through, directly damaging the nerve bundles, squeezing them.
Wow, so it's not just general pressure. It's targeted squeezing and distorting right where the nerve leaves the eye. What about the vascular side, the blood supply?
That can also be compromised. The blood vessels feeding the optic nerve head might lack good autoregulation. They can't maintain steady blood flow when eye pressure changes.
Okay.
Or the high IOP itself can physically compress those small blood vessels right at the lamina cribrosa.
Squeezing the pipes too.
Right. Or there might just be decreased blood flow in the annulus of Zinn, which is a ring of vessels that nourishes this critical area.
And the source mentions systemic factors playing a role too, things outside the eye.
Absolutely. Your overall body blood pressure matters. If the blood pressure reaching the optic nerve head drops too low, maybe because of systemic hypotension or blood vessel spasms, or even acute blood loss that reduces the perfusion pressure.
Perfusion pressure.
That's the pressure gradient driving blood into the optic nerve. So even if your eye pressure isn't sky high, Low perfusion pressure means the nerve isn't getting enough blood.
So the insight here is that it's often a double whammy, or even more complex. Pressure squeezing, blood flow reducing.
And maybe systemic factors making the nerve more vulnerable. It's often a mix.
The source also mentions something about susceptibility.
Yeah, that's interesting. It suggests some people, particularly those with primary open-angle glaucoma, or POAG, might be genetically more susceptible. Perhaps they have larger openings in their lamina cribrosa naturally.
Making them more prone to that mechanical displacement under pressure.
Potentially, yes. More vulnerable to the squeeze.
So, multiple pathways, but they lead to the same outcome. Damaged nerve fibers. What happens at the cellular level then?
Well, that disrupted axoplasmic transport means fewer essential nutrients and signals trophic factors reach the ganglion cells.
Those are the cells in the retina whose axons are the optic nerve, right?
Exactly. Without those trophic factors, the cells get damaged and eventually undergo apoptosis. That's like programmed cell death. And this cell death can even trigger problems in neighboring cells.
Okay, so cells are dying off. How does that loss of nerve fibers translate into something the patient might notice, or that shows up on, say, a vision test?
As you lose nerve fibers, you start developing blind spots, visual field defects. The source notes this loss typically starts, or is most pronounced, at the top and bottom poles superior and inferior poles of the optic disc.
And that location matters.
Hugely. Because of how the nerve fibers are wired from the retina to the optic nerve, the specific polar damage creates a very characteristic pattern of vision loss, usually an arching blind spot above and below your central vision area.
An arc shape.
Yes. And crucially, these defects extend towards the nose, but they stop sharply at the horizontal midline. They do not cross what's called the horizontal rough.
Ah, that pattern not crossing the horizontal line is a key clue for glaucoma then.
A very important diagnostic sign.
So how is glaucoma actually diagnosed using these findings? What's the process?
The diagnosis really hinges on combining clinical signs. The source highlights the core trio. Those characteristic changes in the optic nerve head appearance, visual field abnormalities that match that specific pattern of damage we just talked about, and finding raised intraocular pressure.
The combination is key. And how do doctors figure out which type of glaucoma it is?
That comes down to the overall clinical picture, but a very important step is assessing the anterior chamber angle, that drainage area, using a special lens technique called gonioscopy.
Gonioscopy. To see if the angle is open or closed.
Precisely.
The source gave specific criteria for diagnosing different types, didn't it?
It did. For the most common type, primary open-angle glaucoma, POAG, the diagnosis usually requires seeing at least 2 out of those 3 main signs, the nerve changes, the field loss, or the high IOP.
2 out of 3 for POAG.
But here's a key distinction the source makes. For acute or chronic primary angle closure glaucoma, POAG, and for the secondary glaucomas.
Well, just finding a raised IOP in that specific context is often enough to make the diagnosis of glaucoma.
That's a big difference. Okay, let's zero in on those optic nerve head changes. What exactly is a clinician looking for there? The source really emphasizes that these changes in the optic nerve often appear before the patient notices any vision loss or it shows up on a field test, so they're vital for early detection.
What's normal look like?
Normally, there's a ratio between the central depression, the cup, and the whole optic disc. It's called the cup-to-disc ratio, and it's usually around 0.3 to 1.
And in glaucoma?
That cup tends to get larger, the ratio increases.
What are some specific red flags clinicians watch for?
Okay, several things. Asymmetry is a big one if the cup-to-disc ratio is different between the 2 eyes, especially by more than 0.2.
Okay.
A localized notch or thinning of the neuroretinal rim, that's the healthy pink tissue around the cup that contains the actual nerve fiber.
So the rim gets thinner.
Right. An enlarged cup-to-disc ratio overall, maybe greater than 0.5, and often it enlarges more vertically. Also, regional pallor or paleness of the rim tissue, and sometimes you might see small flame-shaped hemorrhages right on the disc surface.
What about the blood vessels on the disc? Do they change?
Yes, there can be signs of acquired cupping. Things like bearing of circumlinear vessels, where vessels near the rim edge that used to be covered by rim tissue become exposed as the rim thins. Or an overpass sign, where the central vessels seem to take a sharp turn over the deepened cup edge. Changes in the tissue around the optic disc, called parapapillary atrophy, can also be seen.
So these changes aren't static, they evolve. Documenting them over time must be crucial.
absolutely essential, the source stresses. Whether it's careful drawings, taking photos, stereo photos for a 3D view, or using objective imaging like scanning laser ophthalmoscopy or OCT.
OCT, optical coherence tomography, that gives a cross-section view.
Exactly, like a microscopic slice using light. Whatever the method, keeping meticulous records over years is fundamental for tracking progression and guiding management.
Makes sense. Now let's talk visual field abnormalities. Where do those first blind spots typically pop up?
The source tells us they usually first appear in what's called Jerram's area. That's an arc-shaped region roughly 10 to 25 degrees away from your central point of fixation.
And these defects connect back to the nerve damage.
Directly. Those early defects correspond to that damage happening at the superior and inferior poles of the optic nerve head we talked about earlier.
Can you describe some of the specific types of visual field defects mentioned in the source?
Sure. You might start with relative paracentral scotomas.
Relative means?
Meaning you might miss dimmer or smaller targets in that spot, but you can still see brighter or larger ones. Your vision is just less sensitive there.
Okay. What else?
A nasal step is another classic finding. It looks like a horizontal shelf-like defect in the nasal part of your vision, again from that asymmetrical loss at the poles. Sidal scotoma is an early defect that starts near the natural blind spot and arches over the central macula area, but doesn't quite reach the horizontal midline nasally. Then there are arcuate scotomas.
Arcuate, the arching ones.
Yes, these also often start near the blind spot, arch over the macula, tend to widen as they go, and end right at that horizontal midline nasally. But again, they strictly respect that horizontal divide. They don't cross it.
And in more advanced glaucoma.
Those arcuate defects can eventually merge, forming what's called a double arcuate or a ring scotoma. This can leave just islands of vision remaining, usually centrally and out in the temporal periphery.
Until the end stage.
In end-stage disease, the visual field defect can be almost total, sometimes with only a small island of temporal vision left.
Okay, so someone takes a visual field test, like static perimetry. How do you confirm if a defect seen on the test is truly glaucomatous? The source gave pretty specific criteria.
It did. To confirm a glaucomatous defect on static perimetry, you generally need to find one of these patterns. First, an abnormal result on the glaucoma hemifield test, or GHT.
GHT, we'll come back to that. What else?
Or you need to see at least 3 contiguous points that are next to each other and not right on the edge of the test area within that Jerram's area on the pattern deviation plot. These points need to be statistically significantly depressed, meaning their sensitivity is lower than expected, less than 5% probability in normals, and at least one of those points has to be even more significantly depressed, less than 1% probability.
Okay, a cluster of significantly bad points. Any other way?
Yes. Or the overall pattern deviation statistic itself, often called CPSD or PSD, is significantly abnormal, less than 5% probability.
And finding this once isn't enough.
Absolutely not. The source is very clear.
Yeah.
These findings must be confirmed on 2 consecutive reliable tests.
Not twice.
Because patients can have a learning curve with the machine or just have a bad test day. You need repeatability to be sure it's real damage. So you need at least 2 reliable static fields showing consistent defects to diagnose based on perimetry alone, and crucially, you always have to interpret these tests alongside the clinical examination of the optic nerve.
Right, put it all together. Tell us more about that glaucoma hemifield test, the GHT you mentioned.
The GHT is specifically designed to pick up on that characteristic pattern of glaucomatous loss. It compares the sensitivity readings in 5 specific clusters of points located above the horizontal midline with 5 corresponding clusters below the midline.
Looking for that asymmetry across the horizontal line.
Exactly, because glaucoma often affects nerve fiber bundles running either above or below that line first. The GHT flags an abnormal result if there's a statistically significant difference in sensitivity between the upper and lower corresponding zones beyond 1% probability. It flags borderline if the difference is suspicious but slightly less significant between 1% and 3% probability.
So it's tuned to that specific anatomical pattern of damage. And how do you classify how severe a visual field defect is?
The source mentions using the mean defect, or MD value, from the test printout. An MD between 0 and NMX 6 decibels is generally considered mild damage, up to negative 12 is moderate, and anything worse than negative 12 is severe.
Just based on that number.
Well, the MD gives a general idea, but the source says you also need to consider other factors. How many points are actually depressed, how close the visual field loss is to the patient's central fixation point that's critical for function, and whether both the upper and lower halves of the field are involved.
Okay. Are there ways to detect damage even earlier? Maybe before it shows up clearly on a standard field test.
Sure.
Preprometrics diagnosis.
Yes, the source discusses several approaches for that. These include using different types of stimuli during testing, like short wavelength blue light, or stimuli that flicker or appear to double frequency doubled stimuli. Testing sensitivity to contrast, motion, or flicker frequency can also pick up early dysfunction.
And the newer imaging technologies.
Absolutely. Technologies like scanning laser ophthalmoscopy and especially OCT are really important here. They can measure the thickness of the retinal nerve fiber layer, those axons, and analyze the structure of the optic nerve head directly, often identifying loss before it becomes detectable as a functional blind spot on a standard visual field test.
So we've covered nerve damage and field loss. Let's swing back to the pressure itself, IOP. The source mentioned it's influenced by lots of things, even genetics.
Yeah, IOP definitely has a genetic component. It's polygenic, meaning multiple genes influence your baseline pressure, and beyond that, many things can cause short-term fluctuations.
Like what sort of everyday things?
Well, there's a diurnal variation. IOP is often highest in the early morning or sometimes late at night. Lying down flat in the supine position typically causes a rise compared to sitting or standing. It also fluctuates slightly with your heartbeat and breathing cycle.
Exercise.
Interestingly, aerobic exercise usually lowers IOP temporarily, but isometric exercise like straining or lifting heavy weights can slightly increase it. Performing a Valsalva maneuver, bearing down definitely raises it quite a bit.
Drinking fluids.
Blinking.
Drinking large volumes of fluid quickly can cause a temporary rise. Even just blinking can transiently increase IOP by up to 10 millimillar Hg. And forcefully squeezing your eyelids shut can spike it dramatically, maybe by 40 or 50 millimillar Hg.
Wow, just squeezing your eyes. Okay, that gives a sense of its variability. Let's start classifying the different types of glaucoma based on the source. How does it break them down?
The source uses a pretty standard and practical division. It groups them into primary adult glaucoma, secondary glaucomas, and congenital or developmental glaucomas.
And primary adult is split further.
Yes, into the two main categories based on that angle assessment. Primary open-angle glaucoma, POAG, and primary angle closure disease, PCD. Okay, let's tackle primary open-angle glaucoma first, POAG. What are its defining features?
This is the most common type in many populations, especially Caucasians and those of African descent. Key features are: it starts in adulthood, usually affects both eyes, although often somewhat asymmetrically, and the defining characteristic is that the anterior chamber angle is open and appears normal on gonioscopy.
Despite the open angle.
You see those characteristic glaucomatous changes in the optic nerve head, you find corresponding visual field damage, and typically the IOP is measured above 21 millimillar Hg on multiple occasions.
Where is it most common, geographically or ethnically?
It's the most frequent form in Caucasians and Africans. In Asian and Eskimo populations, it accounts for roughly half of primary glaucomas. It usually affects older adults, rarely seen before age 40, and there's often a familial tendency.
Is there a strong genetic link identified?
For the common adult onset form, it's considered multifactorial or polygenic, meaning many genes likely contribute small effects. These genes might influence your baseline IOP, how well your drainage system works, or maybe the structure of your optic nerve. However, a specific early onset form called juvenile POAG has been linked in some families to a gene on the long arm of chromosome 1.
Any other health conditions often seen alongside POA?
Yes, the source mentions that diabetes, mellitus, and myopia nearsightedness seem to be more common in people with POAG compared to the general population.
The source also describes some variations within this POAG category, like normal tension glaucoma.
Exactly. Normal tension glaucoma, NTG, is important. It accounts for maybe 15% or so of patients who have all the classic signs of POA, the optic nerve damage, the characteristic visual field loss, but their IOP is repeatedly measured at 21 millivar Hg or lower.
So pressure isn't the main driver there.
It strongly suggests that for these individuals, those non-pressure factors, like vascular issues or perhaps increased susceptibility of the nerve itself, are playing a more significant role.
And the opposite end, ocular hypertensives.
Right. These are people who have consistently high IOP measured above 21 millimillar Hg, but crucially, they show no signs of optic nerve damage or visual field loss. Their nerves seem to be able to tolerate that pressure level.
And POAG suspects.
These are individuals where the optic nerve appearance looks a bit suspicious for glaucoma, but they don't have definite raised IOP or confirmed visual field changes yet. They need close monitoring. These variations really underscore the point that while high IOP is the main risk factor, it's not the whole story.
So if the angle is open in POA, why does the pressure go up? What's the specific plumbing problem there?
The source attributes the IOP rise in POA mainly to increased resistance to aqueous outflow right at the trabecular meshwork itself.
Huh.
Particularly in the justacanalicular region, that's the very last layer of the meshwork right next to Schlemm's canal.
And why does that resistance increase?
It seems to be partly due to age-related changes occurring within that meshwork tissue, making it less permeable over time.
Clinically, what does POA feel like to the patient? Are there symptoms?
This is a really critical point from the source. Generally, POAG is asymptomatic, especially early on.
No pain, no vision changes initially.
Usually not. The patient doesn't feel the pressure rising, and the initial vision loss is peripheral, so they often don't notice it until significant irreversible damage has occurred. Maybe sometimes non-specific things like mild headaches, needing more frequent changes in reading glasses, vaguely noticing a blind spot, especially down low, or maybe trouble adjusting to the dark. But often, absolutely nothing alerts them.
Which makes the clinical signs the doctor finds absolutely paramount for diagnosis.
Totally. So in someone with a confirmed open angle, the signs the doctor looks for are those optic nerve head changes we detailed, the cupping, asymmetry, rim thinning, maybe hemorrhages, visual field defects that fit the typical glaucoma pattern, an IOP measured over 21 mmHg on more than one visit, or maybe a consistent difference in IOP of more than 5 mmHg between the two eyes. You might also directly visualize defects in the retinal nerve fiber layer using special filters or imaging.
Management then, since the damage is irreversible, catching it early is everything.
It's imperative, the source states. Early detection is key to preventing significant visual morbidity. That's why screening is recommended, especially for high-risk groups like those with a first-degree relative with glaucoma, people with diabetes, high myopes, regularly after age 40. Ideally, everyone over 40 should have comprehensive eye exams that include checking for glaucoma.
And it's a chronic condition, right? Needs
Yeah.
lifelong management.
Yes, absolutely. It requires lifelong follow-up. That starts with getting a really good baseline evaluation documenting the IOP, the visual field status, the optic nerve appearance, and the angle status with gonioscopy. Keeping those detailed records over the years is essential for tracking any changes.
Do you need to recheck the angle later?
Sometimes, yes. Gonioscopy might need repeating if things change, for example, if certain medications are used that could narrow the angle, or just due to normal age-related thickening of the eye's lens.
Is the progression fast?
The good news, generally, is that POA damage usually progresses slowly, typically over years, not days or weeks. This gives a window of opportunity for treatment to work.
What specific things are most important to document to help guide management decisions?
The source highlights a few key things. The IOP level at which damage was first detected, if known, the extent of the damage already present, both optic nerve and visual field, and any associated risk factors the patient might have, like cardiovascular issues or diabetes.
And these help establish a target pressure.
Exactly. This is a crucial concept. It's an individualized IOP range for that specific patient, where the clinician believes further damage is unlikely to occur. It's based on all those parameters we just mentioned. Studies cited in the source suggest that keeping the IOP consistently below about 16 to 18 mmHg stabilizes POVAG in most patients.
So the primary goal of all treatment is just lowering that pressure.
Yes, according to the source, the only currently available and proven treatments for glaucoma work by lowering IOP.
No drugs to directly protect the nerve.
Not yet proven, unfortunately. Though the source does mention one drug, betaxolol, is thought to potentially increase blood flow to the optic nerve, which might be helpful, but direct neuroprotection isn't a current therapy focus based on evidence.
And the main treatment options listed?
Medications, usually eye drops, laser therapy, or surgery. The source notes that these basic treatment approaches are similar across most types of glaucoma, though the specific choices might vary. For POAG, laser trabeculoplasty is a common option if drops aren't enough or aren't tolerated.
Laser trabeculoplasty, how does that work again?
A laser is used with a special contact lens, gonioscopy lens, to apply small burns or treatments directly onto the trabecular meshwork.
What's the theory behind why that helps?
The source mentions a couple of hypotheses. One is that the laser spots cause some tightening or tautening of the meshwork beams, maybe opening up the drainage spaces. Another idea is that it stimulates the meshwork's own cells, endothelial cells, to migrate and remodel the surrounding tissue matrix, improving fluid outflow. Different lasers can be used: argon, diode, frequency doubled, ND.YAG. Typically 50 to 100 spots are applied over about half or all of the angle circumference.
Any immediate side effects to watch for?
Yes, there's often a temporary spike in IOP right after the laser procedure. Because of this, prophylactic anti-glaucoma drops are usually given immediately before or after the treatment. There's also a newer technique called selective laser trabeculoplasty, SLT, which uses a different type of laser energy that causes less thermal damage to the meshwork, but seems to achieve a similar IOP lowering effect.
How much does it lower the pressure, typically?
The average IOP drop is around 5 to 7 millimillers HE. However, the effect can wear off over time, sometimes over a few years. It's generally considered when medications aren't sufficient, if a patient struggles with taking drops regularly, compliance issues, or if the patient prefers to try laser before considering surgery.
Okay, that gives us a really solid picture of POA. Let's switch gears now to the other main primary adult type, primary angle closure disease, or PACD. The source described this as more of a spectrum.
That's right. It's not just one thing, but a range of conditions. The common feature is that the peripheral iris physically blocks the openings of the trabecular meshwork because the angle itself is narrow or occludable. This blockage leads to a rise in IOP.
And the epidemiology who gets this is quite different from POA.
Very different. It's much more common in people of Asian or Eskimo descent compared to Caucasians or people of African descent. In Caucasians, it only accounts for maybe 6% of all glaucomas and usually presents later in life, maybe 60s or 70s. But in many Asian populations, it can be responsible for up to half of all primary adult glaucomas and often presents a decade or more earlier.
Gender difference. Family history.
Acute angle closure attacks are more common in females. The more asymptomatic or chronic forms seem to affect genders more equally. And yes, having a first-degree relative with PACD definitely increases your risk.
What makes an eye anatomically prone to having a narrow angle? What are the risk factors in the eye itself?
The source lists several predisposing factors: having a shorter eye overall axial length, a smaller corneal diameter, a shallower anterior chamber depth, and the lens iris diaphragm being positioned relatively further forward in the eye.
And a key mechanism often involves something called pupillary block.
Yes, that's a primary mechanism explained in the source. Especially in eyes that are smaller to begin with, the natural lens can be proportionately quite large, and the lens continues to grow slowly throughout life, which can further crowd the front of the eye.
Crowding leads to contact.
Exactly. It leads to increased contact between the back surface of the iris and the front surface of the lens. This contact can impede the normal flow of aqueous humor through the pupil, from the posterior chamber behind the iris to the anterior chamber in front. That's relative pupillary block.
So pressure builds up behind the iris.
Right. Pressure increases behind the iris relative to the front, causing the flexible iris tissue to bulge or bow forward, particularly at the periphery. This forward bowing then pushes the outermost part of the iris against the trabecular meshwork, physically blocking the drain.
What can trigger this block to suddenly become complete or acute?
Certain situations that cause the pupil to be in a mid-dilated state are common triggers. Things like being in dim lighting, doing prolonged close-up work, which involves accommodation, making the lens thicker and more anterior, or even experiencing an emotional crisis, which can dilate the pupil via adrenaline.
Why mid-dilated?
Because in that position, the iris often makes maximum contact with the lens surface. If you combine that with an accommodated thicker lens, it can suddenly cause the lax peripheral iris to bow forward significantly, leading to sudden, extensive angle closure and a dramatic, acute spike in IOP.
Are there other suggested mechanisms besides pupillary block?
Yes, the source mentions a few others. One is a plateau iris configuration, where the iris root inserts more anteriorly and bunches up in the angle upon dilation. Another is increased lens vault, meaning the lens itself bulges forward more than usual. Or sometimes it might just be simple crowding of a thick peripheral iris in an already narrow angle.
What are the clinical features like? Is it always dramatic?
It's generally bilateral, meaning both eyes are at risk, but often asymmetrical in presentation. And as we said, it's a spectrum with different subtypes and presentations.
In gonioscopy, looking at the angle is absolutely key for diagnosis here.
It's the definitive test. You diagnose an occludable angle if you cannot see the posterior functional part of the trabecular meshwork over at least 180 degrees. Some classifications use 270 degrees, when looking straight ahead into the angle with the goni lens.
Are there special techniques for examining a narrow angle?
Yes, the source mentions manipulative gonioscopy, where you might ask the patient to look in different directions or gently move the lens to get a better view. And indentation gonioscopy is very important.
Indentation.
That's where the examiner gently presses the gonial lens onto the central cornea. This pressure displaces aqueous fluid out towards the peripheral angle, temporarily pushing the iris root back and allowing the examiner to see deeper into the angle recess to determine if the angle is truly closed by adhesions, synechiae, or just by apposition, iris touching the meshwork but not stuck.
The source mentioned a simplified classification system from the International Society of Geographical Ophthalmology.
Yes, it provides a useful framework with three main categories, based on gonioscopy findings and the presence or absence of damage. Primary angle closure suspect, PASCS, primary angle closure, PAC-C, and primary angle closure glaucoma, PAC-G.
Let's start with PASCS. That's just the possibility of closure.
Exactly. PASCS refers to an eye where appositional contact between the peripheral iris and the posterior trabecular meshwork is possible. You'll see a shallow anterior chamber, and on gonioscopy, the pigmented meshwork isn't visible over at least 180 to 170 degrees without using indentation or manipulation. The angle recess itself is generally narrow, maybe less than 20 degrees. But critically, there are no other abnormalities like adhesions, synechiae, or signs of elevated pressure or damage. It's just an anatomically narrow, potentially occludable angle.
Can they test if it actually can close?
Yes. The source mentions a dark room-prone provocative test, sometimes used for PASCS. They measure the IOP and assess the angle, then have the patient lie face down in a dark room for an hour without falling asleep. Then they recheck the IOP and angle carefully with minimal light. A significant rise in IOP, say 8 mmHg or more, along with evidence of the angle actually closing during the test, identifies someone predisposed to closure. Mydriatic tests, using dilating drops, are less physiological.
Okay, so that's PASCS. What about PAC, primary angle closure?
PAC is the next step up. It's an eye with an occludable drainage angle, plus features indicating that trabecular obstruction by the peripheral iris has actually occurred at some point.
What kind of features indicate obstruction has happened?
Things like peripheral anterior synechiae, PAS, those adhesions forming between the iris and the angle structures, or finding elevated IOP, or seeing specific signs on the iris itself, like distortion or whirling, or those characteristic little white lens opacities called Glaucomflecken, which are remnants of lens cell damage from a past pressure spike, or finding excessive pigment deposited on the trabecular surface.
But still no optic nerve damage at this stage.
Critically, yes. In PAC, the optic disc does not yet show glaucomatous damage. The patient might have experienced symptoms during episodes of closure, though.
What kind of symptoms?
Things like unilateral headache or brow-ash, episodes of blurred vision, or seeing unbroken colored halos around lights. The source mentions a test called the Emsley-Fincham test can help differentiate these halos from those caused by cataracts. Between these attacks, the patient might be symptom-free, and the only signs might be the narrow angle, maybe some pigment clumping, or occasional small synechiae.
So these attacks can be recurrent but short.
Yes, they can be recurrent, short-lived attacks, lasting maybe minutes to hours, causing sharp IOP spikes that then resolve spontaneously. However, repeated attacks like this can progressively damage the trabecular meshwork, leading eventually to a state of chronic raised IOP and progression to the final stage, PAC-G.
Which brings us to PAC-G, primary angle closure glaucoma. That's when the nerve damage is present.
Correct. PAC-G is defined as having PAC, the occludable angle plus signs of past or present obstruction, together with evidence of glaucomatous optic neuropathy, the characteristic nerve damage, and a visual field loss.
The source also provided a more detailed clinical classification beyond just PASCS, PAC.
Indeed, it essentially covered suspect and PAC, as we discussed, and then further detailed acute PAC-CD and chronic PAC-C. Acute PAC-G is that dramatic emergency situation.
The acute attack.
Exactly. A sudden, complete occlusion of essentially the entire drainage angle, leading to an acute, extremely high IOP spike.
Symptoms sound severe.
They are. Intense unilateral headache, often radiating, rapidly diminishing vision and a very visibly red eye. Nausea and vomiting are common due to the high pressure and pain.
And the signs the doctor sees.
Marked congestion of both the superficial conjunctival vessels and the deeper ciliary vessels. Significant corneal edema, making the cornea look hazy or steamy. A very shallow anterior chamber. The iris might be bowed forward, iris bombée. And characteristically, the pupil is often vertically oval and stuck in a mid-dilated position, reacting poorly to light.
What about after the acute phase, if the cornea clears?
Gonioscopy will show the angle is closed, often with extensive iridocorneal synechiae already formed. The optic disc itself might look hyperemic, red initially, or even normal if the attack is very recent. The source also mentions Vogt triad as clinical signs indicating a past acute attack occurred. Sector iris atrophy, a patch of iris thinning, pigment dispersion on the back of the cornea, and those anterior subcapsular lens opacities, the Glaucoma flecken.
Okay, that's the acute form. What about chronic patchy?
Chronic patchy involves a chronically raised IOP associated with synechial closure of 180 degrees or more of the angle in an eye that has an occludable angle structure. And, like the definition implies, there's evidence of optic nerve and visual field damage.
How does this chronic state develop?
The source lists a few ways. It can result from repeated subacute attacks, like those described under PAC, that gradually lead to extensive synechiae and chronically elevated IOP. Or it can follow an acute PAC-C attack that wasn't relieved quickly enough, leading to irreversible synechiae and permanent meshwork damage. Or it can develop asymptomatically through creeping angle closure.
Creeping closure.
Yeah, where synechiae slowly form deeper within the angle recess and progressively involve more and more of the circumference, gradually compromising outflow without necessarily causing dramatic symptoms.
Treatment for PAC-Z, especially that acute attack, needs to be fast, right?
Absolutely. Acute PAC-Z is an ophthalmologic emergency. The immediate priority is to lower that extremely high IOP, often over 50 millimil Hg. This typically involves giving intravenous acetazolamide, a carbonic anhydrase inhibitor, and/or mannitol, an osmotic agent, always checking first for any cardiovascular contraindications.
Why lower the pressure so fast?
To relieve ischemia, lack of blood flow, to the iris, which helps the iris respond better to subsequent treatment, and to decrease the corneal edema so the doctor can eventually see the angle clearly.
What comes next as the pressure starts coming down?
Then, topical pilocarpine 2% is crucial. Pilocarpine is a miotic. It constricts the pupil. In angle closure, this constriction can help pull the peripheral iris tissue away from the trabecular meshwork, physically opening the angle. Other topical anti-glaucoma medications like beta blockers, alpha agonists, are usually added as needed to help lower the pressure further.
What if the pupil block is really stubborn and the iris stays pushed forward?
The source mentions a technique: applying gentle pressure to the central cornea with something like a moist cotton swab. This physically displaces aqueous fluid centrally and can sometimes mechanically push the iris backward, away from the angle.
And once the pressure is under control and the eye is quieter, what's the definitive treatment?
A peripheral laser iridotomy is considered mandatory in all eyes that have experienced any form of PAED, whether it was acute, chronic, or even just intermittent symptomatic PAED. And critically, it's also performed prophylactically in the fellow eye because that eye is typically at very high risk of developing angle closure as well.
Peripheral laser iridotomy. How does that work? What's the mechanism?
It involves using a laser, most commonly an ND-YAG laser, to create a small, full-thickness hole in the peripheral part of the iris.
Like drilling a tiny hole.
Essentially, yes. This creates an alternative pathway for aqueous humor to flow directly from the posterior chamber behind the iris into the anterior, in front of the iris, bypassing the pupil entirely. This eliminates the pressure difference between the two chambers that was causing the iris to bow forward. By equalizing the pressure, it allows the iris to fall back away from the angle structures.
Where's the hole made? How big?
It's usually done in the mid-periphery of the iris, typically superiorly, maybe around the 11 or 1 o'clock position, often where there's a natural thinning or crypt in the iris. The goal is an opening of at least 150-200 microns. Sometimes pilocarpine is given beforehand to make the iris taut and easier to penetrate. The laser is aimed, sometimes with a slight anterior offset, and pulses are applied until a patent opening is confirmed.
What happens after the iridotomy? Post-op care.
Post-operatively, topical steroids are usually given for about 5-7 days to control inflammation, and sometimes anti-glaucoma medications are continued temporarily to prevent an IOP spike. The patency and size of the iridotomy are checked, and gonioscopy is repeated later to assess the angle configuration.
So after the iridotomy, is the glaucoma cured? Is the pressure always normal then?
Not necessarily. The iridotomy effectively treats the pupillary block mechanism, which is often the main driver. However, if significant damage to the trabecular meshwork occurred due to previous high-pressure episodes, or if extensive peripheral anterior synechiae, PAS, are present, the IOP might remain chronically elevated even with a patent iridotomy.
So follow-up is still needed.
Absolutely. Patients are typically reevaluated 2 to 4 weeks after the iridotomy. If the IOP is still found to be chronically elevated, then they will require ongoing management with anti-glaucoma medications or potentially glaucoma surgery, similar to managing POA, aiming for that individualized target pressure.
And the source mentioned one more category under primary adult glaucoma, combined mechanism glaucoma.
Yes, this is diagnosed when an eye has an occludable angle and there are some peripheral anterior synechia present. But the extent of those synechia doesn't seem sufficient to fully explain the level of IOP elevation or the amount of glaucomatous damage observed.
So something else is going on too.
The source suggests the possibility that the patient might have an underlying problem with their trabecular meshwork outflow, similar to what happens in POA, and the angle closure component is either coincidental or acting as an additional factor contributing to the pressure rise.
Okay, that covers the primary adult glaucomas in detail. Let's move on now to the secondary glaucomas. The source emphasized these are quite common, especially in certain settings.
Yes. It highlighted that they form a large proportion of glaucoma cases, particularly in developing countries where things like ocular infections, inflammation, complicated eye surgeries, and trauma are more prevalent. And a key point was that they often go undiagnosed for too long, leading to substantial vision loss before being identified.
What's the basic principle of a secondary glaucoma?
The defining feature is that the glaucoma is caused by some other primary condition or factor affecting the eye. That primary issue is what disrupts the normal aqueous outflow channels.
Can they be open angle or angle closure?
They can be either, depending on how the underlying condition affects the outflow pathway. If the primary problem pushes or pulls the iris forward to block the angle or fills the angle with material, it's a secondary angle closure glaucoma. If the condition damages or clogs the trabecular meshwork itself, but the angle structure remains physically open, it's a secondary open angle glaucoma. Many different pathological conditions can lead to secondary glaucoma, and they might occur more often in eyes already predisposed due to family history or other risk factors.
So the treatment approach is two-pronged.
Generally, yes. You have to identify and treat the underlying primary cause, if possible. And then you manage the elevated IOP itself, aiming for that individualized target pressure, using medications, laser, or surgery as needed, much like in primary glaucoma.
Let's look at some specific examples the source detailed. Inflammatory glaucomas like uveitic glaucoma.
Right. This is a common type of secondary open-angle glaucoma caused by inflammation inside the eye, specifically uveitis.
How does inflammation raise the pressure if the angle is open?
The inflammation directly affects the trabecular meshwork. The endothelial cells lining the meshwork might become swollen and dysfunctional. Or the meshwork itself can get clogged up by inflammatory material, white blood cells, macrophages, lymphocytes, fibrin physically blocking the outflow channels and reducing aqueous drainage. You might even see this inflammatory debris as precipitates on the meshwork during gonioscopy.
And what about post-inflammatory glaucoma? That happens later.
Yes, this occurs after the active inflammation has subsided. If the uveitis was severe enough to cause extensive posterior synechia adhesions between the back of the iris and the front surface of the lens, this can block the pupil, occlusio pupillae or seclusio pupillae, leading to iris bombée and then secondary angle closure by peripheral anterior synechia.
Even without pupil block.
Even without that, repeated episodes of iridocyclitis, inflammation of the iris and ciliary body, can cause chronic scarring and fibrosis within the trabecular meshwork itself, leading to impaired outflow and elevated IOP long after the inflammation is gone.
The source mentioned glaucomatocyclitic crisis, which sounded quite unique. Minimal inflammation, but very high pressure.
It is fascinating, often called Posner-Schlossman syndrome. It's characterized by acute, recurrent episodes. The key is very mild anterior uveitis, but associated with a secondary glaucoma where the IOP rise is dramatically out of proportion to the amount of inflammation seen.
What does it look like?
Patients typically present with sudden unilateral mild discomfort, maybe some blurring or halos, but crucially, the eye often looks relatively white, not very red. The angle is open. IOP can be very high, like 40-50 millimole Hg or even more. Examination shows minimal inflammation, maybe just a trace of aqueous flare, a few cells, perhaps some small, flat, non-pigmented keratoc precipitates on the lower cornea. Importantly, no posterior or peripheral anterior synechia form. The source even notes the inflammation might sometimes seem to appear days after the IOP starts to rise. These attacks resolve spontaneously over days or weeks, but recurrence is common.
In another inflammatory type, Fuchs heterochromic iridocyclitis.
Right. This is a less common, chronic, very low-grade form of iritis. It's often associated with developing a posterior subcapsular cataract and can also cause secondary glaucoma. It's usually unilateral in about 90% of cases, typically affects people in their 30s or 40s, and is often associated with heterochromia, a difference in iris color between the two eyes.
What are the signs of inflammation here?
It's subtle. Low-grade flare in cells in the anterior chamber, characteristic small stellate-shaped keratic precipitates scattered over the corneal endothelium, maybe fine filaments on the endothelium or some anterior vitreous opacities. Sometimes small whitish nodules can be seen on the iris surface. Secondary glaucoma develops in about 15% of patients at the time of presentation. Vision loss is often due to the progressive cataract.
How are these inflammatory glaucomas generally managed?
The first step is always to control the underlying uveitis, usually with topical corticosteroids, sometimes nonsteroidals. While the inflammation is active, you also need to control the IOP medically, aiming to get it below 20 mmHg if possible. Once the inflammation has completely resolved, the need for ongoing glaucoma therapy is reassessed based on the extent of any permanent damage to the outflow pathways and any resulting visual field loss.
Next category. Neovascular glaucoma. Sounds like new blood vessels are the problem.
Exactly. And it's a notoriously difficult type of glaucoma to manage. It typically follows conditions causing extensive retinal ischemia, severe lack of oxygen to the retina. Common causes are central retinal vein occlusion or advanced proliferative diabetic retinopathy.
Why does retinal ischemia lead to glaucoma?
The ischemic retina releases vascular endothelial growth factor, the EGF, and other factors that stimulate the growth of abnormal new blood vessels. These vessels grow on the surface of the iris, called rubeosus iridis, and critically, they grow across the trabecular meshwork and into the drainage angle. As these fragile new vessels mature, they are associated with fibrous tissue that contracts. This contraction pulls the peripheral iris up against the cornea, effectively zippering the angle shut with fibrovascular membranes and causing intractable high IOP.
How do you treat that? It sounds tough.
It is. Treatment has to target the underlying cause. This usually involves injections of anti-VEGF medications directly into the eye to suppress the abnormal vessel growth, combined with extensive retinal photocoagulation, laser or cryotherapy, freezing, to ablate the ischemic peripheral retina and reduce the stimulus for neovascularization. The raised IOT itself often requires surgical management, typically trabeculectomy with potent anti-scarring agents like mitomycin C, or sometimes the implantation of an aqueous drainage device, a shunt or valve.
Okay, shifting gears again. Lens-induced glaucoma. The lens itself can cause glaucoma. How?
Yes, the source describes several ways the crystalline lens can cause secondary glaucoma, either by causing angle closure or through an open angle mechanism.
Let's do angle closure first.
Two main types here. First is phecomorphic glaucoma. This happens when the lens rapidly swells and becomes intumescent, maybe due to a rapidly progressing cataract or sometimes following trauma that ruptures the lens capsule. This swollen, enlarged lens physically pushes the iris root forward, obliterating the drainage angle and blocking outflow.
Sounds urgent.
It is. It requires rapid surgical relief, usually lens extraction. If it's not treated quickly, extensive peripheral anterior synechia can form, leading to permanently elevated IOP even after the lens is eventually removed or absorbed.
What's the second type of lens-induced angle closure?
That's phecotopic glaucoma. This is caused by the lens being displaced from its normal position, either partially subluxated or completely dislocated anteriorly. If the lens is partially subluxated forward, it can directly compress and block a segment of the drainage angle. If it dislocates completely into the anterior chamber, it can block the entire pupil and angle, especially if the iris constricts behind the posteriorly displaced lens.
Okay, so that's closure. How can the lens cause secondary open-angle glaucoma?
This is typically phacolytic glaucoma. It occurs when the lens capsule is compromised, often in a very mature or hypermature senile cataract, allowing lens proteins to leak out into the aqueous humor.
Leakage causes blockage.
Yes. These soluble lens proteins trigger an inflammatory response involving large macrophage cells, phagocytes. These macrophages engulf the lens protein particles. These large, engorged cells are then carried by the aqueous flow into the trabecular meshwork, where they physically obstruct the outflow channels. It typically presents with a sudden onset of high IOP and pain, but the pupil is usually active and round, and examination shows inflammatory cells in the anterior chamber and often whitish keratic deposits on the cornea.
So what's the treatment for these lens-induced glaucomas?
The definitive treatment is surgical removal of the offending lens, ideally after medically lowering the IOP first. It's important to ensure all lens material is evacuated from the eye. A posterior chamber intraocular lens, IOL implant, is often not contraindicated. However, if treatment is delayed, permanent damage to the outflow channels can occur, potentially requiring long-term glaucoma medications or surgery even after the lens is gone.
Next category, pseudophakic or aphakic glaucoma. This is glaucoma occurring after cataract surgery.
Correct. Pseudophakics means the eye has an artificial intraocular lens, IOL. Aphakics means the natural lens was removed but no IOL was implanted. This refers to secondary IOP elevation that can be attributed either to the surgery itself or to its complications. Given the huge volume of cataract surgeries performed worldwide, this is an important category. The source notes it's seen more commonly after pediatric cataract surgery and was more frequent with older designs of anterior chamber IOLs in adults.
Can the pressure rise just be temporary right after surgery?
Yes, a transient open-angle glaucoma can occur in the immediate postoperative period. Common causes include retained viscoelastic material, the gel used during surgery, temporary distortion of the angle from tight sutures, or a significant postoperative inflammatory reaction or bleeding, hyphema, blocking the meshwork. This usually resolves spontaneously over days or weeks and is managed with medical therapy, including topical corticosteroids if inflammation is a factor.
But it can also become a chronic problem.
It can. The IOP might remain chronically elevated, or it might even rise months or years later, particularly noted in pediatric cases. If chronic elevation occurs, a thorough investigation is needed to determine the specific cause.
Can angle closure happen after cataract surgery too?
Yes, secondary angle closure can occur due to pupillary block. This happens if posterior synecdoche form between the iris and the IOL optic, the lens capsule, or the anterior vitreous face in phakic eyes. This blocks aqueous flow through the pupil, causing the iris to bow forward and close the angle.
How's that treated?
Early, fine synecdoche might sometimes be broken with intensive use of dilating drops, mydriatics. If that's unsuccessful or the block is established, a large NWAG laser peripheral iridotomy, sometimes multiple iridotomies are needed, is essential after controlling the initial IOP rise. Breaking the pupillary block can prevent further structural damage and allow the glaucoma to subside. However, if the block persisted for more than a couple of days, chronic IOP elevation needing ongoing medication is likely, even after a successful iridotomy. The source notes that postoperative pupillary block is particularly common in patients with diabetes.
What if the angle stays open after surgery, but the pressure remains chronically high? What could cause that?
The source lists several possibilities. Retained cortical lens material causing inflammation or obstruction, pigment dispersion syndrome induced by the IOL rubbing against the iris, free vitreous strands migrating into the anterior chamber and obstructing the meshwork, or late fibrosis and sparring developing within the trabecular meshwork over time.
And the treatment for that type?
Treatment is generally managed like any other chronic open-angle glaucoma, starting with medications, possibly laser trabeculoplasty if appropriate, or eventually glaucoma surgery if needed. The source also mentions that a transient IOP rise can occur after a Y laser capsulotomy, a common procedure to clear cloudiness behind the IOL, due to capsular debris or inflammatory cells temporarily clogging the meshwork.
Any specific management points for these post-cataract surgery glaucomas?
Systemic medications like carbonic anhydrase inhibitors or hyperosmotic agents can be useful as interim measures for high pressure. The source advises caution with prostaglandin derivative eye drops, as they might increase the risk of cystoid macular edema, swelling in the central retina, in these eyes. Traditional glaucoma filtering surgeries like trabeculectomy tend to have a higher failure rate in these often complex eyes, so anti-scarring agents are frequently used. Aqueous drainage implants are also used with considerable success in these cases.
Okay, another important secondary type. Corticosteroid-induced glaucoma.
Yes, a very well-known cause. The administration of corticosteroids, whether as topical eye drops, injections into or around the eye, or even systemic pills or inhalers, can decrease aqueous outflow facility and cause IOP to rise.
Does this happen to everyone who uses steroids?
No, it's much more common in individuals who are genetically predisposed, so-called steroid responders. The source quotes that about 5-6% of the normal population will experience a marked increase in IOP, over 31 millimilli-HG, after using topical steroids for 4-6 weeks. And importantly, almost all patients who already have POA or even normal tension glaucoma will show some degree of IOP elevation when exposed to steroids.
How does it usually present?
Typically, it presents as a quiet, white, painless eye, but with elevated IOP, characteristic optic nerve cupping, and visual field defects if it's been going on long enough. The drainage angle on gonioscopy looks open and usually appears normal. Because it's often asymptomatic, it can be missed unless IOP is specifically checked in patients on steroids. However, if the IOP rises very high very quickly, it can cause acute symptoms like corneal edema, blurred vision, halos, eye ache, or even redness.
Any theories on why steroids cause the pressure to go up?
The source discusses several proposed mechanisms. One theory is that steroids stabilize lysosomal membranes within the trabecular meshwork cells. This might inhibit enzymes that normally break down glycosaminoglycans, capotegrons, leading to an accumulation of GAGs in the meshwork spaces. GAGs attract water, potentially swelling the tissue and narrowing the outflow channels.
Other ideas?
Another is that steroids might suppress the phagocytic activity of the trabecular meshwork endothelial cells, their ability to act like cleanup crews removing debris, which could lead to further blockage. There's also evidence suggesting that individuals with POA might accumulate an abnormal metabolite of cortisol, dihydrocortisol, in their trabecular cells, which could potentiate the effect of exogenous steroids. And finally, steroids are known to inhibit the synthesis of certain prostaglandins, like PGE and PGF, which normally help lower IOP by increasing aqueous outflow.
How is steroid-induced glaucoma treated?
The first and most crucial step is to stop the corticosteroid administration, if medically possible. Then, the elevated IOP needs to be controlled medically, often with standard glaucoma eye drops. The source notes that in about 1/3 of affected eyes, the IOP will gradually return to normal levels after the steroid is stopped. However, the remaining 2/3 may require long-term glaucoma treatment, managed similarly to POA.
Pseudoexfoliation syndrome, this involves flaky material?
Yes. Pseudoexfoliation, PX syndrome, is characterized by the deposition of a distinctive fibrillar, grayish-white, dandruff-like material on various structures in the anterior part of the eye. You see it on the iris surface, in the ciliary body region, and classically on the anterior lens capsule, often in a target-like pattern. This exfoliative material also collects in the drainage angle, physically obstructing the trabecular meshwork.
Is it just in the eye?
No, it's considered evidence of a more widespread systemic degenerative process affecting the anterior uvea and potentially other body tissues. The key point for glaucoma is that individuals with PECs have a significantly higher risk of developing glaucoma, which can be either open angle due to meshwork blockage or sometimes angle closure if the material causes iris changes or pupillary block.
Pigmentary glaucoma, this involves pigment release.
Correct. This is a form of secondary open-angle glaucoma typically seen in younger individuals, more often males, who are usually myopic, nearsighted. It's caused by pigment granules being rubbed off the back surface of the iris.
Why does pigment get rubbed off?
It's often due to a specific anatomical configuration where the peripheral iris bows backward slightly and chafes against the lens zonules, the fibers holding the lens in place, during normal pupil movement or accommodation. These liberated pigment granules are then carried by the aqueous flow throughout the anterior chamber.
Where does the pigment go?
It deposits on various structures, classically forming a vertical line on the back surface of the central cornea, called a Krukenberg spindle. Importantly, the pigment granules also get swept into the drainage angle and clog the trabecular meshwork, leading to increased IOP. Gonioscopy shows characteristically heavy, uniform pigmentation of the meshwork, sometimes with a distinct line called Sample-Lacey's line.
Do patients notice symptoms?
They might experience intermittent symptoms like blurred vision or halos, especially during activities that might cause more pigment release, like exercise. The source states that about 1/3 of individuals diagnosed with pigment dispersion syndrome, the condition of having the pigment release without yet having high IOP or nerve damage, will eventually develop pigmentary glaucoma. However, the long-term prognosis with treatment is often relatively good, with significant field loss occurring in only a minority.
Elevated episcleral venous pressure, how does that cause glaucoma?
This relates to the final step in aqueous outflow. After filtering through the trabecular meshwork and Schlemm's canal, the aqueous humor drains into the episcleral veins on the surface of the eye. If the pressure within these veins is abnormally elevated, it creates a back pressure that impedes the drainage of aqueous from Schlemm's canal, thus raising the IOP.
What kind of conditions can raise episcleral venous pressure?
The source lists several causes. Conditions within the orbit, eye socket, like inflammations or tumors that compress the veins, abnormal connections between the carotid artery and the cavernous sinus in the brain, carotid cavernous fistulas, which transmit high pressure to the orbital veins, thyroid eye disease causing exophthalmos, bulging eyes, Sturge-Weber syndrome, which involves vascular malformations, and orbital varices, dilated weak-walled veins in the orbit.
An intraocular tumor can also cause secondary glaucoma, but not just by taking up space.
That's an important distinction the source makes. While a very large tumor obviously occupies volume, the glaucoma associated with intraocular tumors is usually not due to simple mass effect. Instead, it's typically caused by neoplastic tumor cells infiltrating and directly blocking the drainage angle structures, or by tumor cells seeding into the aqueous humor and clogging the trabecular meshwork.
And one more complex one, aqueous misdirection syndrome, also called malignant glaucoma or ciliovitreal block.
Yes, this is a challenging condition. The underlying problem is that the normal forward flow of aqueous humor from the ciliary body through the pupil into the anterior chamber is somehow blocked or prevented. Instead, the aqueous gets misdirected posteriorly, flowing backward into or accumulating within the vitreous cavity, the gel filling the back of the eye.
What does that backward flow do?
It increases the volume of the vitreous humor. This expanding vitreous then pushes the entire iris lens diaphragm forward in eyes with a natural lens or an IOL, or pushes the anterior hyaloid face forward in aphantic eyes. This forward displacement shallows the anterior chamber dramatically and pushes the peripheral iris against the cornea, closing the drainage angle secondarily and causing a marked rise in IOP.
Who is prone to this? When does it happen?
It's more likely to occur in eyes that are already small and hyperopic, far-sighted, particularly those with pre-existing angle closure glaucoma, often occurring after surgical procedures like iridectomy, filtering surgery, or even laser iridotomy. However, it can also occur following routine cataract surgery, YG laser capsulotomy, or sometimes even spontaneously without any preceding surgery.
What are the symptoms and signs?
Patients typically experience severe eye pain and blurred vision. The hallmark clinical sign is an extremely shallow or even flat anterior chamber, despite the presence of a patent iridectomy, if one exists, combined with very high intraocular pressure.
Is it easy to diagnose?
It's crucial to differentiate it from other potential causes of a flat or shallow anterior chamber with high IOP postoperatively, such as a choroidal detachment, simple pupillary block, which should be relieved by a patent iridotomy, or a suprachoroidal hemorrhage. Gonioscopy and sometimes ultrasound biomicroscopy, UBM, can help.
How is aqueous misdirection managed? That sounds tricky.
Medical management is usually the first line. Intensive cycloplegic drops, especially topical atropine 1%, are very important.
Why cycloplegics? Don't they dilate the pupil?
They do, but they also paralyze the ciliary muscle. The theory is that relaxing the ciliary body might tighten the lens zonules, causing the lens to thin slightly and shift posteriorly, which can help deepen the anterior chamber. Strong osmotic agents, like IV mannitol or oral glyceryllysis sorbide, are also used to dehydrate the vitreous body and lower IOP. Aqueous suppressants, topical beta blockers, alpha agonists, carbonic anhydrase inhibitors, are added to reduce fluid production.
Does medical therapy always work?
It can be effective in some cases, but the source notes that atropine might need to be continued for months or even years to prevent recurrence. In pseudophakic or aphakic eyes, performing a Y laser hyaloidotomy, creating an opening in the anterior vitreous face, can sometimes reestablish forward aqueous flow.
What if conservative measures fail?
Then surgical intervention is necessary. The definitive treatment is usually a pars plana vitrectomy, surgically removing a significant portion of the vitreous gel, often combined with lens extraction, lensectomy, if the natural lens is still present. This reduces the vitreous volume and creates a clear pathway for aqueous to flow forward. Even after successful surgery, long-term medical therapy might still be needed to control IOP. Prognosis for IOP control is better now than in the past, but the condition can recur, and the fellow eye is always considered at high risk.
Okay, that covers a huge range of secondary glaucomas.
Yeah.
Let's shift gears completely now to the pediatric glaucomas. Our source mentioned these are much less common, but perhaps underestimated.
Yes, significantly less common than adult forms, and they are often associated with other systemic syndromes or ocular developmental abnormalities. The source does suggest that their true incidence and impact might have been underestimated in the past.
Congenital glaucoma is specifically defined by age of onset.
Yes. The term congenital glaucoma generally refers to glaucoma that presents from birth up to about 3 or 4 years of age. A key distinguishing feature of glaucoma presenting at this early age is that the eye wall, the cornea and sclera, is still relatively soft and distensible.
So the eye stretches.
Exactly. Unlike in adults, where high pressure mainly causes optic nerve cupping, in infants and very young children, elevated IOP causes the entire eyeball to enlarge noticeably. This enlargement is called ophthalmos.
Ophthalmos, the ox eye. Is congenital glaucoma usually inherited?
Most cases of primary congenital glaucoma, where it occurs without other major ocular or systemic findings, are sporadic. However, about 10% of cases are hereditary, typically following an autosomal recessive pattern. Genetic research has linked congenital glaucoma to defects on at least 3 different chromosomes, with mutations in the CYP1B1 gene being the most commonly identified cause. It can be primary, as mentioned, or secondary, associated with various syndromes or occurring after injury, cataract extraction, or inflammation in infancy.
What goes wrong developmentally in the angle in primary congenital glaucoma?
It's due to a failure or abnormal development of the trabecular meshwork and angle structures during gestation. There might be incomplete separation of the iris from the cornea, leaving the angle covered by persistent embryonic tissue, like Barkin's membrane. Or the iris might insert too far anteriorly into the angle recess or even directly into the trabecular meshwork itself.
What's the result?
The result is impaired aqueous outflow and a permanent rise in IOP. The source notes that the IOP elevation isn't usually as acutely marked as in adult angle closure, perhaps because some alternative outflow pathways, like uveoscleral flow or drainage via anterior ciliary veins, might still provide some limited circulation. Neonatal congenital glaucoma presenting right at birth often involves more extensive angle malformations and carries a poorer prognosis.
How else does the eye's distensibility in children affect the presentation compared to adults?
As we said, the globe enlarges, ophthalmos. Also, the lamina cribrosa can give way more readily, leading to rapid and often deep optic nerve cupping. The stretching of the cornea can cause breaks in its inner layer, Descemet's membrane, leading to corneal edema and haze. And interestingly, the very fact that the eye is stretching can sometimes mask the degree of underlying pressure elevation during an examination under anesthesia.
Are there any common syndromes associated with pediatric glaucoma?
Yes, the source specifically mentions neurofibromatosis and Sturge-Weber syndrome, which involves the characteristic facial Port-Weinstein angioma, along with vascular malformations in the eye and brain, as conditions commonly associated with glaucoma in childhood.
Clinically, what are the key signs and symptoms that parents might notice? What should they look out for?
The classic symptoms that parents often detect are ophthalmos, noticing that one or both eyes are getting progressively larger, a hazy or cloudy appearance to the cornea due to that stretching and edema, excessive tearing, epiphora, and marked photophobia, extreme sensitivity to light. The infant might seem very irritable, frequently rubbing their eyes or even burying their head in a pillow to avoid light.
And what signs does the clinician look for, often requiring an examination under anesthesia?
It's generally bilateral, although often asymmetrical, and slightly more common in boys. Early signs might just be that ground glass, corneal appearance, tearing, and the marked photophobia. Later, more specific signs appear. Discrete corneal opacities, often linear with a double contour. These are the habstriae, the healed breaks in Descemet's membrane, typically running concentric to the limbus. Obvious enlargement of the corneal diameter in the entire eyeball is seen. The sclera, particularly in the ciliary region, might appear thinned and bluish due to the underlying uveal pigment showing through.
How does the corneal shape change?
The stretching at the junction of the cornea and sclera can make the cornea appear more globular, sometimes resembling another condition called keratoglobus, which needs to be differentiated. The anterior chamber is often noted to be extremely deep.
Deep? That seems counterintuitive if the pressure is high.
It does, but it happens because as the whole globe expands, particularly the ciliary ring, the lens gets flattened and displaced posteriorly due to stretching of the suspensory ligaments, zonules. This backward lens movement removes support from the iris, which may then appear tremulous with eye movements, iridodonesis. The eyes usually become myopic due to the increased axial length, but often less myopic than you might expect because the lens flattening and backward displacement partially compensates. IOP is typically measured in the 30s mmHg range or higher.
Can it ever stabilize on its own?
The source notes that in some cases an equilibrium might be established, perhaps as the meshwork undergoes some postnatal development, potentially leading to reversal of cupping and no further vision loss. However, in many others, rapid deterioration occurs if not treated promptly.
Treatment for pediatric glaucoma. The source said medications aren't usually the main approach.
Correct. Medications are generally considered not very effective as a primary or long-term treatment for most forms of congenital glaucoma. The most effective treatment is surgery aimed at directly addressing the anomalous angle architecture to allow aqueous to reach the canal of Schlemm.
What are the main surgical procedures?
The two classic procedures are goniotomy and trabeculotomy.
Can you briefly describe those?
Goniotomy involves inserting a special knife through the limbus across the anterior chamber and, under direct visualization using a gonio lens, incising or sweeping away the abnormal embryonic tissue covering the trabecular meshwork, typically over about 75 degrees of the angle circumference. Trabeculotomy approaches the angle from the outside. A conjunctival and partial thickness scleral flap are made to expose Schlemm's canal. A small, specialized probe, trabeculotome, is carefully threaded into the canal and then rotated internally to break through the inner wall of the canal and the overlying abnormal meshwork, creating an opening into the anterior chamber. This is often done in two sections to open about half the canal circumference. Locating Schlemm's canal externally can sometimes be challenging.
What if the cornea is too cloudy for goniotomy, or in more severe cases?
For severe cases, or when corneal edema or opacification prevents adequate visualization for goniotomy, a combined trabeculotomy-trabeculectomy procedure, possibly with pharmacological modulation, anti-scarring agents, might be considered.
What's the prognosis after surgery?
Surgery is often successful in controlling IOP, but the source emphasizes that more than one operation is frequently required. The prognosis tends to be worse if the glaucoma is present right at birth, neonatal onset, and generally best if it presents between 2 months and 1 year of age.
What about juvenile primary open-angle glaucoma, juvenile POAG? That's different from congenital.
Yes. Glaucoma presenting between the ages of 4 and 10 years is sometimes termed late congenital or developmental glaucoma, implying the trabecular anomalies might be less severe than in the infantile form. True juvenile POA is generally defined as POA occurring between the ages of 10 and 35 years. The source notes that about 35% of individuals with juvenile POA are also high myopes.
And the cause here is often genetic.
Yes, there's often a strong autosomal dominant inheritance pattern. Some families with juvenile POA have been linked to genetic defects on the long arm of chromosome 1, specifically the GLC1A locus. Numerous mutations have been found in the gene located there, which produces a protein called TIGR, trabecular meshwork inducible glucocorticoid response, or myocilin.
How does myocilin relate to glaucoma?
The current understanding, as mentioned in the source, is that abnormal myocilin protein likely makes the trabecular meshwork less permeable to aqueous outflow. Interestingly, the source also notes that in susceptible individuals, treatment with steroids might increase myocilin production, potentially contributing to the IOP rise seen in steroid-induced glaucoma.
Okay, we've covered a huge amount on the different types. Let's try to bring it all together now and consolidate the general principles of management, drawing from everything the source discussed. The core message seems to be: glaucoma is chronic, requires lifelong care.
That is the absolute cornerstone. Patients really need to understand this from the outset. Effective management involves continuous supervision by an ophthalmologist with regular monitoring.
What does that monitoring involve?
Key components are measuring IOP accurately, usually with applanation tonometry, carefully assessing the optic nerve head status, often including imaging like OCT or photos, and performing careful, repeated visual field charting to detect any changes over time.
When should treatment actually begin?
The source is clear. Treatment should be initiated as soon as a definite diagnosis of glaucoma is made.
Why the urgency?
Because, as we've stressed, vision loss from ganglion cell damage is irreversible. The entire goal of treatment is to minimize or, ideally, prevent further vision loss by consistently controlling and monitoring the intraocular pressure.
So the main treatment modalities we discussed were medicines, laser, and surgery. Initial treatment is usually medical or laser.
That's the typical starting point for many types, especially POAG. And for any patient with chronic glaucoma, the clinician needs to establish that individualized target pressure we talked about earlier.
Remind us what goes into setting that target.
It takes into account the IOP level at which damage was first known to occur, any family history, the extent of damage already present on both the optic nerve and the visual field, and any systemic risk factors the patient might have that could make their nerve more vulnerable, like vascular disease, diabetes, etc.
How is medical management generally approached?
For situations with very high IOP, like acute angle closure or sometimes severe secondary glaucomas, immediate lowering might be needed using intravenous agents like acetazolamide or mannitol. For moderately high pressure, oral options like acetazolamide tablets or glyceryl sorbide solution can work within about 30-60 minutes. Bringing the pressure down quickly allows topical medications to then work more effectively. However, systemic medications are generally not advised for long-term use due to potential life-threatening side effects.
What about the standard eye drops? Which groups are considered first line according to the source?
The source identifies beta blockers, alpha-2 agonists, and prostaglandin analogs as the most effective classes and generally the first-line choices for initial therapy in open-angle glaucoma.
What if one drug isn't enough?
If the first drug tried doesn't lower the IOP sufficiently to reach the target pressure, the usual approach is to substitute it with a different drug from another first-line class. If a drug lowers the IOP significantly, say by 15–20%, but it's still not quite at the target level, then an adjunctive drug from a different class, working via a different mechanism, is typically added.
Are miotics still used?
Miotics, like pilocarpine, are considered essential in the acute management of primary angle closure glaucoma until a laser iridotomy can be performed because they help pull the iris away from the angle. They are less commonly used long-term now in open-angle glaucoma due to side effects like brow ache and blurred vision.
Using multiple different eye drops can have downsides.
Definitely. Increasing the number of topical medications increases the potential for local and systemic adverse effects, and it also significantly decreases patient compliance. It's just harder to remember, and instill multiple drops correctly every day. The concept of maximal tolerated medical therapy is reached when the IOP is controlled as well as possible with medications while still allowing the patient a good quality of life without unacceptable side effects. If IOP control is still insufficient on maximal tolerated medical therapy, then laser trabeculoplasty, if appropriate, or surgical intervention is required.
Surgical treatment, when is that typically the next step?
Surgery is commonly undertaken when medical therapy, with or without laser, fails to arrest progressive visual field loss. It's also considered for patients who are non-compliant with medications, those who are unable to attend for regular follow-up reviews, or in cases where the IOP is simply too high to be adequately controlled by medications alone. In some situations, surgery might even be considered as a primary therapy option, aiming for a very steady low IOP around the clock.
The main category of surgery mentioned was glaucoma filtering operations, creating a filtering bleb.
Yes, that's the most common surgical approach. The goal of these operations is to create a new pathway for aqueous humor to drain from the anterior chamber, bypassing the blocked natural outflow channels into the subconjunctival space under the outer membrane of the eye. Here, the fluid forms a small reservoir, the bleb, from which it is absorbed by surrounding tissues and blood vessels, creating a small opening or fistula between the anterior chamber and the subconjunctival space that heals into a loose, permeable scar tissue channel. A filtering cicatrix is the key.
And the most favored operation of this type?
Trabeculectomy remains the gold standard filtering surgery. The source also briefly mentioned that non-penetrating filtering surgeries, like deep scolectomy or viscocanalostomy, which aim to allow drainage through a very thin remaining membrane, like Decimet's membrane, without creating a full thickness hole, are also being evaluated.
Can you describe trabeculectomy again in a bit more detail? How does it work?
As described in the source, it involves first creating a partial thickness flap in the sclera, the white part of the eye. Underneath this flap, a small block of deeper tissue is excised. This block includes a small piece of the sclera itself, a short length of Schlem's canal, and the adjacent trabecular meshwork. Removing this piece creates an opening from the anterior chamber directly under the scleral flap.
So it creates a new channel.
Yes, it effectively creates two potential new outflow routes. Some aqueous may enter the cut ends of Schlem's canal, but the primary route is through the hole created, the sclerostomy, into the space under the scleral flap, and from there, percolating around the edges of the flap into the subconjunctival space, forming the bleb. So it relies on both improved access to the canal and transscleral flow to the subconjunctival space.
What's the biggest challenge with filtering surgery? Scarring.
Absolutely. The body's natural healing response is to try and close that surgically created fistula. If wound healing is too aggressive, scar tissue can seal the scleral flap down or block the subconjunctival space, causing the surgery to fail and the IOP to rise again.
How is that managed?
To counteract excessive scarring, especially in eyes considered at high risk for failure, like in younger patients, people of African origin, eyes with previous surgery or inflammation, antifibroblastic agents are often used during the surgery. The most common ones are 5-fluorouracil, 5-FU, or mitomycin C, MMC. These drugs are applied briefly to the surgical site on sponges to slow down the proliferation of fibroblasts, the cells responsible for scar tissue formation, thereby increasing the chances of long-term success. The source mentions typical concentrations and application times, for example, 5FU 50 mg/ml, MMC 0.2 mg/ml for 1 to 3 minutes.
What does a successful trabeculectomy bleb look like after surgery?
The source describes the ideal appearance as a diffuse, slightly elevated area of the conjunctiva, often pale, located superiorly near the limbus, sometimes showing tiny bubble-like changes, microcysts, within the conjunctival tissue, which indicate good filtration.
Are there common complications associated with trabeculectomy?
Yes, like any surgery, early postoperative complications can include a very shallow or flat anterior chamber, hypotony, or bleeding into the anterior chamber, hyphenode. Later on, the main concerns are bleb failure due to scarring, infection of the bleb, blebitis, which can lead to serious intraocular infection, endophthalmitis, or persistent bleb leakage.
Shallow anterior chambers sound like a significant issue.
They are relatively frequent early after surgery and can be problematic. If the chamber is too shallow for too long, it can lead to complications like cataract formation, corneal decompensation, or eventual failure of the filter itself due to adhesions forming. Management often involves trying to reform the chamber early, sometimes using substances like balanced salt solution, air, or viscoelastic injected into the eye. Using releasable or adjustable sutures in the scleral flap during the initial surgery can help modulate outflow in the early post-op period and reduce the risk of excessive hypotony.
And bleb infections.
Blebitis and subsequent endophthalmitis are serious late complications, particularly associated with thin-walled vascular blebs, which are more common when potent antifibroblastic agents like MMC have been used. Patients need to be educated about the warning signs.
What if the patient also has a significant cataract?
If a visually significant cataract coexists with glaucoma needing surgery, the surgeon might choose to perform the trabeculectomy first and the cataract surgery later, or increasingly perform a combined procedure, phacoemulsification with IOL implant plus trabeculectomy, at the same time.
What about those drainage devices or shunts? When are they used?
Aqueous drainage devices, which can be valved, like the Ahmed glaucoma valve, or non-valved, like the bare belt implant, consist of a small tube inserted into the anterior chamber connected to a larger plate placed further back under the conjunctiva. These are typically reserved for more complex or refractory glaucomas where standard trabeculectomy has already failed or is considered very likely to fail due to high risk of scarring, Iri-G neovascular glaucoma, uveitic glaucoma, previous failed surgeries.
Okay, let's wrap up with prognosis. The source had a stark warning about delaying surgery.
It did. It made the point that, in cases where surgery is indicated, more eyes are ultimately lost to progressive glaucomatous damage by delaying necessary surgical intervention than are lost due to complications of the surgery itself. It underscores the importance of timely and definitive IOP control when medical or laser therapy is proving insufficient.
And it's crucial to remember that surgery only controls IOP. It doesn't reverse existing damage.
Absolutely vital point from the source. Surgical success is measured by IOP control. If the patient's vision loss was primarily driven by the high IOP, then successful surgery should prevent or significantly slow down further loss. However, if the IOP is already relatively low or well controlled, but vision continues to deteriorate, it suggests that other factors, perhaps vascular insufficiency or inherent neurodegenerative processes, might be the main drivers. In such cases, vision might continue to worsen despite a technically successful surgery that lowers IOP even further.
So the overall prognosis really hinges on early action.
Yes. Prognosis fundamentally depends on early diagnosis and initiating adequate treatment promptly before significant optic disc cupping and irreversible visual field loss have occurred.
And continuous monitoring is key to knowing if treatment is working.
Essential. Ongoing, lifelong monitoring of IOP, optic nerve head appearance, preferably with objective documentation like imaging, and serial visual field testing is crucial to detect any subtle signs of medication tolerance developing or disease progression occurring over time.
How do you reliably determine if the visual field is actually getting worse?
It's challenging. The source emphasizes the need for a reliable baseline, recommending at least 3 good quality field tests when newly diagnosed. Follow-up tests should ideally use the same machine and testing parameters. Any apparent change detected on a single test needs to be confirmed on at least one subsequent test to rule out variability, and it must always be correlated with the clinical findings, like changes in the optic nerve appearance or IOP. The source suggests it might typically take at least 6 reliable exams performed at regular intervals, for example, every 3 to 6 months, to confidently confirm statistically significant progression.
Are there specific tools to help analyze visual field changes over time?
Yes, the source mentions the use of statistical software packages that are often built into modern perimeters. Examples given include guided progression analysis, GPA, or the Paradata program. These tools use statistical methods to analyze changes in threshold sensitivity values at individual points or clusters of points across multiple tests, helping to identify trends that might represent real progression.
But even these statistical analyses need careful interpretation.
Definitely. The source provides important caveats. For instance, the development or progression of a cataract can cause a generalized depression of the visual field, which might be flagged as progression by the software, even if the glaucoma itself is stable. Other conditions, like retinal vascular disorders, can also cause visual field defects that could mislead the analysis. Statistical outputs must always be interpreted within the context of the patient's overall clinical picture.
And what if progression is confirmed, even though the patient seems to be at their target pressure?
The source states that if definite progression is established despite the IOP being consistently within the previously set target range, then that target pressure needs to be reconsidered and revised downwards. A lower target needs to be set. Additionally, it prompts investigation into other potential contributing factors that might be affecting optic nerve head perfusion or vulnerability.
Okay, we have really gone exceptionally deep into the source material on glaucoma today. Let's try to summarize the absolute key takeaways, just reinforcing the core concepts for everyone listening.
Right. So fundamentally, glaucoma is that chronic progressive optic neuropathy. Raised IOP is the main modifiable risk factor we target. The damage involves loss of retinal ganglion cells and their axons, likely due to a combination of mechanical stress from the pressure and ischemic damage from compromised blood flow. This leads to characteristic optic nerve cupping and those specific patterns of visual field loss.
And classification is broadly based on the drainage angle, open or closed, determined by gonioscopy.
Exactly. POAG, the common open angle type, is typically managed initially with medications, first-line agents being prostaglandin analogs, beta blockers, or alpha agonists. Laser or surgery comes into play if the target IOP isn't reached or maintained.
And PADI, the angle closure type,
requires that initial NDYAG laser iridotomy to resolve the pupillary block mechanism, often preceded by miotics in the acute setting. Then it's followed by medical or surgical therapy as needed to manage any residual IOP elevation due to meshwork damage or synechia.
and monitoring is absolutely crucial for all types, lifelong.
Non-negotiable. Regular ongoing monitoring with tonometry, careful optic nerve head evaluation, often with the imaging, and serial perimetry is essential to track the disease, ensure treatment effectiveness, and detect any progression early.
The most devastating effect is, of course, the irreversible visual loss.
But, and this is the crucial message of hope from the source, in most cases, with appropriate and timely management, further vision loss can be stabilized. And because central vision is often affected relatively late in the disease process, it just underscores the critical importance of proper screening programs and achieving early diagnosis.
And those diverse secondary glaucomas follow similar management principles.
Yes, very much so. They're common after things like trauma, prolonged corticosteroid use, proliferative retinal conditions like diabetic retinopathy, and anterior segment inflammation. The key there is always to try and address the underlying cause first, and then manage the resulting glaucoma by controlling the IOP to an appropriate target level.
Wow. It is incredibly clear from this deep dive just how complex glaucoma is. Understanding it really requires grasping these multiple intricate mechanisms, recognizing the diverse ways it can present clinically, and appreciating the absolute necessity of vigilant, personalized, lifelong management. The irreversible nature of the vision loss really does drive home the high stakes involved in getting the diagnosis and treatment right, and importantly, doing it early.
It really does. And what strikes me as particularly fascinating, drawing specifically from the details in our source material today, is this interplay between pressure and other factors. While lowering IOP is clearly our main therapeutic lever, we saw in the pathogenesis section how critical blood flow and perhaps inherent nerve susceptibility are.
Right, those non-pressure factors.
Exactly. And then in the prognosis section, the source explicitly acknowledged that vision can sometimes continue to deteriorate even when we think we've achieved our target pressure, or even in situations like normal tension glaucoma, where the pressure was never particularly high to begin with, or in certain secondary glaucomas after the primary cause is addressed.
It really brings back those other elements influencing the outcome.
It does. And it leads to, I think, an important point for you, the listener, to consider, based only on what this source has presented. Given that some forms of glaucoma and some instances of continued progression despite seemingly adequate IOP control strongly suggest that factors beyond just intraocular pressure are playing a significant role in damaging the optic nerve and ultimately determining the visual outcome. How does that inherent complexity challenge a management approach that focuses perhaps too heavily or solely on lowering pressure? And what does our source material implicitly suggest about the importance of considering and potentially addressing these other elements that might influence the long-term prognosis, even after we've successfully treated the eye pressure itself?
That's a really powerful thought to end on. It suggests that even within the seemingly straightforward goal of managing pressure, there are deeper, more complex layers that ultimately dictate whether we succeed in preserving vision.
There certainly are. And truly mastering the subject means grappling with those complexities.
Thank you for joining us for this very deep dive on glaucoma.